Welcome to Dementia series, and I'll be talking about normal pressure hydrocephalus. Normal pressure hydrocephalus as a type of differential diagnosis of dementia. Hydrocephalus is not only found in pediatric age group, but communicating hydrocephalus with normal opening pressures are also found in adults, and that could be as a result of insidious onset. And because it is communicating, most people with hydrocephalus in childhood can still cope with normal life until old age, when it will then come down with possible urinary incontinence, gait disturbance, and dementia. So many people will wrongly diagnose normal pressure hydrocephalus as Alzheimer's disease. This is a surgically treatable condition, but because Alzheimer's disease on its own can also be part of the pathophysiology, and because it's run in the family, it is very easy to miss the diagnosis. But with the presence of urinary incontinence, gait disturbance, and dementia with decline in function, then there should be the suspicion of normal pressure hydrocephalus. Pathophysiology. CSF is produced by choroid plexus and is expected to be absorbed by arachnoid villi, but hypertension and a host of other factors that can increase intracranial pressure will lead to this. Some postulated that Alzheimer's disease plays part in ventricular enlargement. Hence, Alzheimer's disease plays part in normal pressure hydrocephalus pathology. What are the possible risk factors? The identified ones here could be trauma or subarachnoid hemorrhage, which could be secondary to trauma, bleeding disorder, intravenous malformation, head injury, or cerebral aneurysm. It could be as a result of obstructive sleep apnea, hypertension, meningitis, heart failure, and insidious congenital hydrocephalus that would not give problem in childhood, but when they become old at 70 years or 80 years and above. What are the possible clinical features? There is a triad of urinary incontinence, dementia, and gait anomaly with wide base. Those are the three main pathognomonic features that will be occurring concurrently: urinary incontinence, dementia, and gait anomaly. There's possibility of hyperreflexia, mutism, hemiparesis, apathy, cognitive impairment, including decline in executive functions. And of course, urinary incontinence here will be in form of urinary urgency. What are the possible differential diagnoses here? Of course, Alzheimer's disease, and like I've said, because it's going to present close to the late ages of 70 to 80 years, many clinicians will rush to diagnosis of Alzheimer's disease. But with the presence of gait anomaly, urinary incontinence, associated with this decline in cognition, then we should rule out normal pressure hydrocephalus. It's possible we may be dealing with dementia with Lewy bodies or Parkinson's dementia, frontotemporal dementia, Wilson's disease, HIV dementia complex, vascular or multi-infarct, or it could even be urinary tract problem like urgency or incontinency or overflow. Possible diagnosis, yes, to take appropriate history, physical examination, magnetic resonance imaging, CT of the head, urinalysis and urine microscopic caution sensitivity to rule out renal problem, electrolytes, renal function test, lumbar puncture. Yes, when you do lumbar puncture and about 40 minutes of CSF is removed and you check the gait after 1 hour, there should be improvement. And if you are able to pick that improvement, then you are dealing with normal pressure hydrocephalus. When you assay the content of your CSF, it's likely you're going to pick tau protein. Surgery is the cure here, and that is going to be ventricular shunting. In conclusion, don't miss the diagnosis. Correct diagnosis will lead to a good outcome. Thanks for listening to my presentation. Kindly subscribe so that you can get this as soon as I publish. Thank you.